Thank you, Professor Aubert, for joining us. We really appreciate it. A little background, Nikki and I were fortunate enough to take his class, PHP 650, on the cost of prescription drugs last semester, and really enjoyed our experience and all the knowledge we gained. So um, it's really exciting to be back a few months later and having a discussion on kind of some of the advancements we've seen with COVID vaccines and just news around vaccines therapeutics that are going on. So be interesting to pick your brain a little bit. But I think before we start, it'd be great for you, Professor Albert, to give us a little bit of background of kind of what you do, maybe a quick summary of your career path and where you are now.
Sure. So I'm not what I consider a traditional academic. I'm from Los Angeles, California. That's where I was born and grew up. I when I was in graduate school, well, I went to college and I studied biology, and I went to graduate school in the School of Public Health and studied epidemiology, um, and then decided to do the PhD in epidemiology. And I knew at that time that I didn't want to write grants for the grant, I had to be good at it. So I'm more of an applied person anyway. So I took a job at the Center for Disease Control initially as an epidemic intelligence service officer. People now refer to as the disease detectives. And I did that which is a 2-year fellowship. And then I stayed around at the CDC for another 8 years. And then I started getting interested in questions around healthcare financing, healthcare delivery. So I moved to a health outcomes research group in a health plan. And as I told you all in class, once you jump to the private sector, you sign up for a certain amount of instability. So that company was sold to a competitor. Then I moved and moved to the Northeast, took a job as a pharmacy benefit manager, which again was a piece of healthcare. I had no idea what that meant. So it was a learning experience for me also, but that was fascinating. And I was there for quite a while. But again, the unthinkable happened. We got bought by a smaller competitor. It was a big company, got bought by a smaller competitor, and had to find a job. So I worked as a consultant for 5 or 6 years, and then had the fortunate opportunity to come to Brown for a 1-year appointment as a provost visiting professor. Did that for a year, and then went to work at a pharmaceutical company for about a year and a half, and got the call from Brown to come back. And so this is my 3rd year of a 3-year stint at Brown. I'm really excited that worked out. So here on campus, I'm in the Department of Health Services, Policy and Practice within the School of Public Health. Again, I'm an epidemiologist by training, but health services research is a type of epidemiology, I think. And so I teach in the healthcare in the U.S. class, which is probably one of the largest, most popular classes on campus. And then you all were in the 2nd iteration of my class that focuses on the high cost of pharmaceuticals, which is evolving all the time and having a lot of fun with. And we had a great semester, I think, last semester. Great class.
Great, thank you so much. We're glad to have you here. Like Ford was mentioning, we learned a lot in your class, and you talked a lot about, we're hearing COVID vaccines, buzzword in the media, and something you taught us is the difference between efficacy and effectiveness, and especially like how people misinterpret that in news media. So would you mind trying to clarify that for other people to be aware of when they're looking and reading through COVID vaccine media?
Sure, that's a great question. I probably go a little overboard with that because I'm I get a little carried away about it. But efficacy, and I think part of it is the fault of the public health community when they take these common terms and they give them different meaning. Because these are terms that are part of everyday language, and we've given them different meanings in the context of epidemiology and statistics. But efficacy, when it comes to clinical trials, now vaccine trials, it means how does an intervention, in this case vaccines, how does that work under ideal circumstances? Because remember, a trial is an unusual circumstance because everything is almost sort of idealized. You're not going to miss appointments. They're going to make sure that you make your appointments. People are calling you, they're collecting lots of information they're recruiting people in a way that makes it easier for them to stay in the trial, follow the protocol, and to get to be able to answer the question, does the intervention work? Okay. Effectiveness, as we talked about in this space, has to do with, all right, once the vaccine or the drug has been approved, and now it's in the real world, under normal real world circumstances, how does the drug perform? Or how does this vaccine perform? And those things can be, now, right now, it doesn't matter in the way it's handled in the press, because everything is efficacy, whether they say effectiveness or not, because the only data that we have right now is from the trials. So where it's going to get complicated is when we get to the phase 4 trials, or the phase 4, or phase 4 meaning that now people are vaccinated, there are going to be people that are going to be followed, and we're going to see how the drug or the vaccines perform under real world conditions, where the inclusion exclusion criteria are now relaxed, because now almost anybody should be able to get it. And then will they still perform in the same way as they did in the trial? And the other thing to think about is that if you have a vaccine that has a complex regimen, will it perform as well as it did in the trial in the real world? So 2 doses versus 1, freezing, deep freezing, thawing, making sure it's administered within a certain amount of time before the temperature expiration, with the temperature allotment expires. So for example, these vaccines are very unstable at certain temperatures. So after it reaches this, once you throw them out, you have to sort of inject people fairly quickly. So that's a bit of a complexity that you have to take into account once you go into the real world. So that's the basic fundamental difference between the efficacy, which is again, ideal circumstances within the confines of the trial. And that's where we get the numbers. When we talk about, does the vaccine work? We're talking about efficacy as it relates to the trial. And so what you'll hear in the media, you'll hear, there's always a question, how effective is it? What's the effectiveness? Now that's from the perspective of, epidemiology and public health, from a measurement perspective, we're not really gonna know that till we get to the real world evaluation of trials, which will probably not happen until, I'm guessing, maybe this fall, when you start to get people who've been in the trials for like a year or 6 months, will know things like duration, will know things like how common were side effects in a broader population, things like that, and whether or not you get the same sort of response that you saw in the trials.
Amazing. Yeah, I remember learning that in class and was kind of blown away, and also blown away by just after the class, you read these articles and you just see, NBC News, like these very big news sources, credible, misusing terms like efficacy and effectiveness. So I know that was
it's a difficult thing to do, because it's hard to keep using efficacy just from a language perspective. And I think right now it doesn't really matter that much. Where it's going to get complicated when we're talking about effectiveness studies, how they're going to deal with that and reconcile how they were referring to it previously. So no, but as long as you have a good understanding of the difference, trial circumstances, efficacy, real world effectiveness, and we'll see effectiveness probably another several months from now.
Totally. So this next question kind of ties into what we were talking about, but we're having this conversation, I think about a week after the J&J vaccine received the emergency use approval, and we started to see their vaccines, I think 4 million rolled out this week.
Right.
And would just love to hear your thoughts on, where you think our country's heading in terms of, cases and how these vaccines will help. I know having J&J in there with single dose can be kept, I think, at like a refrigeration type temperature. So just love to hear your thoughts on where you think we're heading, if we're heading in the right direction.
Sure. I think the Johnson & Johnson vaccine was going to be a real complement to the 2 really outstanding vaccines that are already available. And I think the trap that people are starting to get into is trying to compare and trying to diminish J&J because it didn't have the same level of efficacy as we observed in the first two, Moderna and Pfizer. Now, that's a tricky trap to play into because there's a couple things to keep in mind. One, when the first two, Moderna and Pfizer, were completed, that was sort of a different time period where there weren't very many variants that were circulating in the population. And so they really had a look at how well their vaccines performed with what was the dominant variant at the time, but not a lot of the dominant virus at the time, not a lot of variants. Now, Johnson & Johnson completed their trials at a time when you had a lot more variants circulating, and they had sites in two of the countries where the most concerning variants right now are coming from, South Africa and Brazil. So that's just a different, it's like an apples and oranges comparison right now. And the fact that they achieved 66% overall efficacy, but if you look at it geographically, there were 64% in South Africa, which is actually quite good, and 66% in Brazil, and 72% in the United States. Now, the reason that's important is because, one, there are different variants that are important in different parts of the countries. From a global perspective, Johnson & Johnson is doing a great job also. The other thing that we tend to lose sight of is that the FDA threshold for this was 0.5, that if or 50%. And let me just kind of make sure we understand what that means too, because people get confused about that. People talk about, well, if it's only 50%, it's good. It's like a 50-50 chance that I'll get it. I don't want to do that, but that's not what that means. 50% reduction, it has to do with the reduction in risk. So 50% efficacy means you reduce the risk by 50% of what it would have been without the vaccine. That's kind of a big public health impact. There's not many interventions that we have anywhere, particularly in the chronic disease space, especially, where you can reduce risk by that much. So 66% is actually a big deal. If they had come out first, people would be going crazy. They would thought that's great. And so I think we're losing sight of the fact that that it's also another really good sort of contribution to the armament of vaccines. The other thing that you alluded to, one shot, and it's a one and done. So when they talk about delivering 100 million doses, that's 100 million people potentially vaccinated versus 50 million of the other two. So that's another big thing that can help accelerate the number of people who actually get vaccinated.
Great, that was so great. I'm glad that you brought up that point about the 50% efficacy rate, reduction rate, because I remember learning that in class and was like, I did not know that, and it's good to know. So now we're kind of just going to open up the floor. If you have like any additional advice or clarifications you would like to share with the public.
Yeah, there are two things that have come out recently that I would direct people to. So on Wednesday, there's a New York Times article that is titled "What is meant by vaccine efficacy" or something like that. And it's written very, very well, very eloquently, all the great graphics, the typical with the New York Times article like that. And so people should really take a look at that and get to understand that. The other thing that I think would be really helpful is on Thursday there was a podcast from the Daily titled something like "When or How Will the Pandemic End?" And as part of that, they talk about the same thing, the points that you all are bringing up around 3 good vaccines are available. They go through the same sort of analogy that we just talked about with respect to the value of Johnson & Johnson. And I guess the conclusion is really that there are 3 great vaccines that are available. And if you have a chance to get one, just grab it, whichever one it is. I mean, people are trying to strategize and come up with, ways to not get one and get the other one and that sort of thing. And I think, if you have a chance to get either of the 3, we should just grab it. And I really hope that we can accelerate the distribution because I think the supply is no longer going to be a problem. There's indication right now that the supply issue will be solved. And so then the challenge is going to be getting vaccines into people's arms, and the extent that we can accelerate that, I think that'll sort of put us in a much better position going forward. Any other questions for me, from the two of you?
I think that I think you hit on a bunch of very important points, and don't want to overload our listeners with too much information. I think this is some critical stuff that hopefully they have some good take home messages. But I know Nikki and I just want to thank you for doing this podcast, and also for a great semester last semester, and your continued support for all that we continue to do. And yeah, just appreciate all your work and relationship.
Oh, it's my pleasure. I so much enjoyed that class last semester. Hopefully we can get as good a class next semester.
Absolutely.